Okay, we have a busy program today, so I'm actually going to get started as close to time as possible this morning. So welcome everybody. So lovely to see those of you here in the auditorium and as well on Zoom. Before we get started today, I just want to note a few announcements. Next week's Grand Rounds, we have the Alexander H. Glassman Lecture, and we will have Jessica Schleider from Stony Brook University. She's the Assistant Professor of Clinical Psychology there. And her talk will be Scaling Single-Session Interventions to Bridge Gaps in Mental Health Ecosystems. And this talk will be in person. And as always, as with today, following the Grand Rounds presentation, there will be a light lunch prepared in the auditorium directly outside. So before I turn it over to Dr. Lisa Dixon, who is going to introduce our rounds today, I just want to highlight a couple of options for our folks on Zoom. So first of all, if you have any questions for our speakers today, please write your questions in the Q&A tab at the bottom of your screen, not the chat. And if you are a trainee, please note trainee after your name, as we like to prioritize those questions. Also, if you would like to ask your question yourself and speak directly to our guests, which I think is a much nicer way to do this, please note at the end of your question, I prefer to have my question read, or I can ask the question myself. And then Jeff Miller, who is my co-host today on Zoom, will temporarily promote you, and you will be able to speak directly with our speakers. Also, for those of you here in the auditorium, there are QR codes at various places, so please scan those for your continuing education credits. Okay, so now I'm going to turn it over to Dr. Lisa Dixon to open our rounds. Thank you.
Good morning, everybody. It's a pleasure to be here and to host our awardees. I am very privileged to introduce the winners of the Mumford Award for 2022. So who is Dr. Mumford? Dr. Mumford was a sociologist and professor of clinical sociomedical sciences in psychiatry and public health at the College of Physicians and Surgeons at Columbia University, and chief of the Division of Health Utilization and Policy Research at the New York State Psychiatric Institute. Importantly, Dr. Mumford stressed the human side of medical care and the importance of the social and cultural context. She placed special importance on the relationship between the clinician and the patient and on the role of family in healthcare. She also studied economic dimensions of health and mental health care. And so this lectureship is founded to preserve our attention and honor those who are focusing on these interests. She is also known for her work on the effect of psychotherapy in lowering later medical costs. Studies in which she took part reported that the person who undergoes psychotherapy develops a healthier style of living and is less apt to require unneeded hospitalization. Thus, the cost of psychotherapy is offset, her study showed. Her writings included a textbook on medical sociology, interns, from students to physicians. The committee members for this award included myself, Mark Olfson, Harold Pincus, Milton Wainberg, and Anne-Marie Albano. We could not be happier to honor this year's awardees, Drs. Héctor R and Glorisa Canino. And I'm just going to be very, very brief, say a few things, but then I'm going to turn it over to Dr. Duarte, who has had the opportunity to work with these two wonderful individuals and will give a more personal and nuanced kind of introduction to their work. So in terms of Dr. Canino, over the past 35 years, she has dedicated her academic career to research oriented to understanding and improving the health of Latino populations in the island of Puerto Rico and in the mainland. She is a professor at the School of Medicine, Department of Pediatrics, and the director of the Behavioral Sciences Research Institute at the University of Puerto Rico. She has had numerous R01 grants and other grants and papers and papers and papers. really just so impressive and important. Dr. Bird, who many of you know, completed his MD at Yale. Since 1986, he has been associated with Columbia and the New York State Psychiatric Institute, where he went up the ranks starting at assistant professor and retired as professor emeritus in 2006. Like Dr. Canino, he has had a long series of research grants and hundreds of publications in the peer-reviewed literature. He has been recognized as an outstanding clinician by New York Magazine over many years, and he has an outstanding record of teaching and mentoring. So I'd like to turn over the microphone to Dr. Christine Duarte, who has worked with these two wonderful contributors and who will share her perspective on their amazing accomplishments.
Hi, everybody. You hear me? So thank you, Dr. Dixon and the Mumford Award Committee for inviting me to share today this special moment. I'm very excited to join the committee and our community in honoring Héctor Bird and Glorisa Canino. So Héctor and Glorisa are formidable scientists and outstanding mentors. In partnership, they incorporated the experiences of Puerto Rican children into the developmental psychopathology science that we still struggle to make more inclusive to this day. I would like to briefly say a word or two about each one of them, and then to convey to you what I think is the central value of their scientific contribution to our fields. So I'll start with Héctor, who was my mentor during my postdoc and then beyond. So Héctor's scientific reasoning is impeccable. The public health relevance of his work is not at all divorced from its clinical practice. His writing is lucid and crystalline. As a professor emeritus, he has kept as an active contributor to all our research efforts, while also volunteering as supervising residents at Ponce University in Puerto Rico. And all of that, of course, is scheduled around his love for the opera and Latin American literature, and peppered with a kind but sharp humor that so many of us have benefited from, making daily events in academia and beyond more digestible. About Glorisa, I can think about very few challenges we face when conducting a research study that Glorisa would not be able to resolve. I know that my colleagues here and on Zoom are nodding. Leading a large and extraordinary team, she has shed light on so many critical topics, from child and adult mental health to alcohol use disorders and asthma in the island. An avid swimmer in the Bahia de San Juan and lover of Latin American art, Glorisa is an example to all of us of determination, energy, and initiative. Today, when they describe behavioral trajectories of 2,500 children in the South Bronx and in the island of Puerto Rico, what may not be too obvious is all the work done to properly bridge these two contexts. Starting with skilled translations from English to Spanish, but by no means stopping there, Glorisa and Héctor have tirelessly made sure that all our research efforts accurately capture cultural values, perspectives, and meaning. I always think, as we now strive to achieve another type of translation in science, how good can we be if we're not getting it right at the very fundamental level that they have been able to achieve? No matter how much we try, sitting comfortably here at Columbia University, there is just too much that we miss. I will illustrate this point with some extracts from a parable in a book by Mia Couto, who is a Mozambican writer of Portuguese descent. He says, this is my translation, in the rural areas where I work, there is a curious way of answering questions posed by a stranger, especially if these questions ask for the cruel dichotomy of yes and no. This is resolved as follows: always answer yes, and simply don't say no. And then later on, he says, but this elegance of approach sometimes creates problems for those who need clear and concise answers. This was my case when I arrived in a coastal area and needed to organize my work. My question, is the tide coming in? The answer once happened this way. It's going up, yes, sir, but it started going down more than 2 hours ago. Another time, with the mission of identifying the fauna in a forest, I asked the old man who accompanied me, is this singing a bird? Yes, he said. And what is the name of the bird? I wanted to know. You see, this bird, we here in Yasa don't call it a well bird. We call it a frog. Another time, during the assessment of the impact of a government motto for the better future, the television of Mozambique carried out a popular survey of the population. The question was, do you feel that your life is improving? One person responded like this: it is getting better, yes, sir, but it's getting better very badly. So Glorisa, commenting on this passage, said, and again I translate, these answers are typical of cultures like ours, where a lot of effort is put into avoiding conflict to maintain good relationships. This is why it's so important how we ask questions. Instead of asking, is the tide going out? We should ask, is it the tide going down or rising? Instead of asking, is it a bird that is singing? It is better to ask, what is singing? It prevents one from having to say no to the person who is asking the question. Me encanta el cuento. I love this passage, she ended. Hector's and Glorisa's careers are live examples that it is possible to communicate and understand realities beyond our own living rooms. In the process, as you will hear today, one generates science that can result in broader conclusions about the world, testing if our theories, models, and mechanisms are valid and have similar impacts in different contexts for different groups. Extending their work by following up the next generation of children who are part of the Boricua Youth Study has been a privilege to me. As a leader of the next generation who follows in their footsteps, I take seriously the responsibility of continuing to produce science as rigorous, insightful, and meaningful as the one that they have launched. Muchísimas gracias, Héctor and Glorisa, for your vision, for being relentless in pursuing your goals, for the mentorship and the partnership. And I'll step aside, not to delay any longer, all of us hearing from them. Thank you. And I think we're gonna ask both to come up here to give them the award first. So we should be here in the middle.
Oh, okay.
Yeah, yeah.
Right, well, thank you very much. Both Glorisa and I are extremely honored by this distinction. And of course, it's a distinction that not only is awarded to the two of us, but to a large number of people, some of you here in the audience, who have joined us in our efforts over the years. Central to our work has been the work that Christiane has continued with the data from the Boricua youth study and the development of that study. I thought, how do we condense over 25, 30 years of work into one talk? And I felt that perhaps it would be more interesting to look a little bit into the history behind what came to be the Boricua youth study. My career at Psychiatric Institute in Colombia didn't start in 1986. It actually started long before that, because both my training in psychiatry and child psychiatry took place in this department in the early 70s. I remained in the department until I moved back to Puerto Rico for a few years in 1980. And that was for personal reasons. At that time, I became the director of child psychiatry in the department where Glorisa was the director of psychology. So although our relationship predated that encounter, we became professionally related at that time. We were, as part of our job, we were both consultants to the to Dr. Aida Guzman, who was the head of the Department of Mental Health within the Department of Health. And we, in our meetings with Dr. Guzman, she came to us and would say, you know, I need to have some data from Puerto Rico because the data that I go to the legislature to request funds is from New Zealand or from the Isle of Wight in England or places that don't have anything to do with Puerto Rico. And they asked me, yeah, but what is the nature of the problem here? So for that reason, we she wanted us to get some data from Puerto Rico, and it nudged both Glorisa and I on our adventure, I should say, in psychiatric epidemiology, something for which neither one of us had trained. With Glorisa as the principal investigator and myself as a co-investigator, we conducted the first study of the adult population of Puerto Rico with a great deal of support from both locally as well as from NIMH. And the samples for that survey was a household sample that was representative of the population of the island of Puerto Rico. And we did that study, and I felt, you know, we have a sample of households. Maybe we should just go in and do some child behavior checklists on the kids in those households and at least get some cursory information. Now, after consulting with many experts, the suggestion was that perhaps I should do our own child study in Puerto Rico, which we did. Maddie Gould joined us in Puerto Rico. She flew down when she was expecting her twins and helped us with the methodology, and she helped us to write the proposal that we submitted to NIMH and for which we obtained funding. That was a two-stage study with a design very similar to the Isle of Wight that Michael Rotter had done. And we used the child behavior checklist as a screening instrument and then got the results of that study. It was carried out in the early 1980s. How does this work? I was trying to do it. Let me see. Yeah. Yeah. We need some technical help here. The beeper, the thing doesn't work. Huh? Just yeah. Well, I tried, but that wasn't working. Okay. All right. Thanks. Thank you. Now, the results of that study gave us a surprising finding, which was that the rate of DSM-3 conduct disorders in the island was found to be extremely low when you compared it to studies of the child and adolescent populations that were being done elsewhere, where the rates, in Puerto Rico, we found something like 1.5% of our sample had those diagnoses. And elsewhere, the reports were that close to 4 to 7% of the population had these disorders. We felt perhaps the differences were attributable to differences in the methods that we had employed or differences in the age groups that were being investigated. So it was very difficult to really make comparisons between our study and other studies. In 1986, I came back to PI and brought the data set from that Puerto Rico study, and Glorisa and I continued collaborating, writing papers and so, from the results. But the rest of the reports were being done from here. Shortly after my return to PI, the NIMH developed an interest in doing a child study of the child population in the United States, very similar to what they had done with the ECA with the adult population. And they decided, though, that prior to embarking on that, they should do a preliminary study in which we would test the methods and the different sampling techniques and so on in a more limited way than a broad national study. So they developed what became known as the MECA study, standing for Methodology for Child and Adolescent, for the Epidemiology of Child and Adolescents. And they chose 4 university sites to carry out. So, okay, the wait. Okay, the sites were in Atlanta at Emory University, Westchester County, with our study here at Columbia. Yale, New Haven, at Yale at New Haven, and also the Puerto Rico site was chosen. So the, we had many measures that were selected from existing measures as well as measures that we developed for that study, including a revision of the diagnostic interview schedule for children that was spearheaded by David Schaffer with a great deal of input from Prudence Fisher, who has taken it on afterwards. And the translation of the disc into Spanish was done by Glorisa and her team in Puerto Rico. The study in Westchester County was implemented with Christina Owen's invaluable input because she already had developed studies in Westchester County that were germane to what we were doing. But one of the important things about the MECA study was that at all of the 4 sites, there had been representative samples. All the children were in the same age range, 9 to 17 years, so that we actually could get some preliminary comparisons and preliminary data on both rates of childhood disorders as well as how they compared across the sites. So each site had representative samples, so of course that enabled us to make some comparisons. Again, we found that the rates of DSM-3R this time, disruptive disorders, were low. Wait. I must have hit the wrong key. Okay. Now, the other thing that drew our attention was that the vital statistics in Puerto Rico showed San Juan to be to have a population where there were very high crime rates, and especially the homicide rates, which generally tend to indicate the rates of criminality because most homicides, or I should say all homicides, are generally reported. So that would gave us an idea that there were high rates of antisocial and sociopathic disorders in Puerto Rico. It was, the question that came up in our mind was that it was paradoxical to find such high rates of DSM disorders in the what we would anticipate to be high rates of DSM disorders in the adults, and there were such low rates in the children. So Glorisa and I then decided that we should conduct a study of the antisocial behavior in Puerto Rican children, which is what led us and what later became known as the Boricua Youth Study. At that time, Roth Lover had just finished the Pittsburgh Youth Study, so that he was able to counsel us and provide us with a large number of measures that they had employed in Pittsburgh, and that we could include in the protocols that we were going to employ in our study. Now, the methodological details of the Boricua Youth Study are too long to explain here, but it was initially and you can read about those in our published papers if you're interested, but the study was originally a 3-wave study, each wave 1 year apart from the previous one. The baseline age of the children was 5 through 13 years. And the sample involved was a sample of children in the South Bronx of Puerto Rican background and a sample of children in Puerto Rico. And we were able to get some pretty good numbers, over 1,300 children in Puerto Rico and over 1,100 here in the Bronx, in the South Bronx. And we had very, what would be considered very high compliance rates for, epidemiological studies. They were over 85% at both sites, and the follow-up rates were also over 80, in the 80s and 90s. And as Glorisa will later discuss, we obtained a 4th wave 11 years later, which has been conducted by Christiane and Glorisa. we used a theoretical scheme that Rolf Loewer had proposed. Okay. Loewer's theory emphasizes a developmental sequencing and unfolding of antisocial behavior along a dimension that goes from less severe to more severe antisocial behaviors as people get older. The theory proposes that a number of children manifest difficult temperaments earlier in life, some of them developing an oppositional defiant disorder in early childhood, and of those decreasing proportions evolving to different levels of conduct disorder and in either childhood or adolescence. And in Loewer's view, the diagnosis of ODD can be seen as involving earlier and milder forms of antisocial behaviors that subsequently can progress to conduct disorders and eventually develop, culminating in antisocial or psychopathic disorders in adult life. So it was within this theoretical framework that we conducted our study. Now, the principal aims of our study were simple and classical epidemiology. We wanted to estimate prevalence and view developmental course, determine risk factors, and evaluate the impact of comorbidity. What I think was unique about our study was that we could compare two populations of the same ethnicity in two very different environmental contexts. The South Bronx, where the Puerto Rican population is a minority, and the metropolitan San Juan, where by definition they're the majority. Now, let me jump ahead a little bit so that I don't take up all the time. The one issue that concerned us was that the rates of conduct disorder and oppositional defiant disorder are generally low, no matter what, in younger children. And CD and antisocial personality, again, are low rates and are really the endpoints of antisocial behavior. So we decided to develop our own measure that we called the Antisocial Behavior Index. And to do that, we used the items that we had in the different instruments that we were using. The DISC-4 at this time, which gave us about 26 items from the oppositional defiant disorder and CD schedules of the DISC. We used Loewer's Elliott scale and the delinquency scale for children and the delinquency scale for young adults, all together at the different frequencies at which these things are elicited. We had over about 110 items. And what we did was we listed all of these antisocial behaviors at the different frequencies. And we asked a group of 9 clinician experts that were either child psychiatrists or child psychologists to independently give a rating of the severity or seriousness of the behaviors at the frequency stipulated. And they were instructed to take into account what they would consider normative developmental expectations in terms of the ratings. So each behavior was rated at the levels of 0 to 5, going from non or trivial to very serious behaviors or serious behaviors when they occurred more than once. That provided us then with a scheme in which to rate each subject, because we rated each subject at the level of antisocial behavior at which their highest score. And starting with level 2, 2 behaviors at a previous level became a rating at the next level. The classification, though, permitted us as a tracing of subtle changes that may develop over time in the trajectory of antisocial behavior, and whether there was escalation, persistence, or de-escalation of the behaviors. Some of our most salient findings in the first 3 waves were that overall the rates of antisocial behavior were similar in the island and in the South Bronx at baseline. As expected, the older children were more antisocial than the younger. The higher rates were in the Bronx than in Puerto Rico. And the rates seemed to increase more markedly in the South Bronx as the kids got older, especially and surprisingly the girls. And we concluded that the living in the South Bronx yielded a greater risk, because although the rates did not increase, the rates actually went down slightly over the 3 waves. They seemed to decrease more markedly in Puerto Rico than they did in the South Bronx, yielding the conclusion that they were, more at risk in the Bronx. Let me see. The risk factors seem to be those that you traditionally associate to antisocial behavior, like older age, sensation seeking, poor family functioning, and so on. And in Puerto Rico, the risk factors or the associated factors seem to be those that we tend to think of as more as protective. In terms of the categorical diagnosis, which we looked at, the risk seemed to be similar for categorical diagnosis as it was for antisocial behavior levels. So in both sides, males were higher and the risk was greater. And as you will see, we looked at the trajectories both in the group of the younger children at baseline and the older children at baseline, and they followed similar patterns, except of course the older were a little higher than the younger. But as you can see, they start similarly. The girls are in the purple line and the boys are in the blue line. Although they start similarly, the Bronx seem to stay higher, and the Puerto Rico lower, and the same for boys and the girls. So, and this is the younger children, and these are the older children, where the results are the same. So to summarize, the results showed that both categorical diagnosis and level of ASB, the same ethnic group shows the similar patterns in the 2 settings, suggesting that the differences are a function of context rather than of ethnicity. And as expected, both cross-sectionally and longitudinally, the risk for boys is greater than girls. Older children have greater risk than younger. The trajectories seem to decline, and this may be a function of an attenuation phenomenon. And the attenuation is a phenomenon that Lee Robbins first described as something that occurs in longitudinal work where you use repeated measures over time, so that as you repeat a measure, and she found this to be true even after a 1-year interval. When you repeat a measure, the positive responses seem to go down. for whatever reason. Probably it's a learned response, or that people consider that if a mild behavior has been addressed before, they don't necessarily have to tell you again about the same thing. In any event, I think what was most important in our findings was that the same ethnic group showed the similar patterns of disruptive behavior disorder and antisocial behavior in the two settings, strongly suggesting that the differences were more a function of context than of ethnicity. Now, the study has continued with Christiane and Glorisa leading the fold. And I will yield the microphone to Glorisa so she can tell you about what has been found in more recently. Aquí.
No, pero aquí. Okay,
Ese es el primero.
okay. Okay, este no es el primero porque había una introducción, pero olvídate, it's better. Okay, fine. Well, I'm glad to be here in the presence of so many of the people we have worked before. And I want to thank Christiane and everybody here who has helped us. I mean, we couldn't have done this without Columbia University and all the staff, to tell you the truth, you know, obviously. Okay, so I had an introduction, and I'm glad that the introduction is not here because we're overextended. So let's start with this. Our focus will be with the most severe manifestation of ASB also on wave 4. You know, Hector presented today wave 1 to 3. And today I'm going to be presenting wave 4, which includes late adolescence and young adulthood. And these are it's the same cohort that we have been following since they were kids, okay? So the most severe manifestations of ASB, that is level 4 and 5, were combined as what we called ASB 4+, you know, since these are associated with involvement in criminal activity and the justice system, and teenage pregnancy and low educational attainment and psychiatric and substance use disorders. We also focus this presentation on the long-term effects of serious ASB4 that start either in childhood or early adolescence, and its outcome in early adulthood. Okay, so what's the definition? ASB4 means very serious ASB, or when 2 or more serious conduct behaviors occur more than once, reflecting the most severe ASB. Serious ASB 4+ are stable and associated with more serious consequences. Okay. I'm gonna skip that. Results of serious ASB in 4 waves. That's what I'm gonna be showing you. Okay, so we have ASB index scores, wave to 1 to 3. As you could see, Hector presented this, 10.4 in Puerto Rico and 15.5 in the South Bronx. And then we have the males and females for the first 3 waves. And then wave 4, you can start seeing the difference, you know. Late adolescence and young adulthood was wave 4, as I said before. And here you see the dramatic difference. Obviously, as Hector said before, ASB increases with age, and now we're talking about young adults. So in Puerto Rico, we had 17.6% of the serious ASB, and in the Bronx, dramatically different, 42.3%. If you look at the rates by sex, you see in 39.6 in the males and 16.8 in the males in Puerto Rico, and then 42.2 in the males in the Bronx, and 17.8 in the females. So so the proportion of respondents who had ASB4 at wave 4 is broken down by peak ASB level 1 in waves 1 and 3 by gender and site. And you could see again what I presented to you before, how it varies tremendously by the age of the respondents, you know, and by site, you know, much higher in the wave 4 than at wave 1 to 3, and much higher in the Bronx than in Puerto Rico. Okay, so the results are stratified by age, gender, site to understand changes in ASB over time, adjusting for age, higher frequency in young men than in young women, was longer at wave 4 than wave 1 and 3, larger, I mean, as was the side effect, higher frequency in the South Bronx than in Puerto Rico. And the age group effect also varied by wave, with older children at wave 1 to 3 having higher ASB than younger children, but age effect was not present in wave 4. And here is a graph showing the difference between sites. As you can see, it's pretty dramatic. This is the development of serious ASB from childhood, early adolescent left, and to late adolescence and young adulthood, which is the right side, by age, cohort, gender, and site, separated, okay? Does serious ASB in childhood increase the risk for ASB in late adolescence, early adulthood? The risk of future ASB was doubled for youth who had serious ASB earlier, after adjusting for gender, age, and side effects. And while some trends were apparent, there was no strong evidence that this risk varied consistently across gender or site. So obviously, having serious ASB puts you at risk for later ASB. Does serious ASB in childhood predict SUD, substance use disorder, major depressive disorder, and teen pregnancy at wave 4? And are any such effects explained by concurrent ASB4 in wave 4? 3 sets of logistic regressions with SUD, MDD, and teenage pregnancy at wave 4 specified as outcomes were adjusted for site, gender, and age group, and no evidence that early serious ASB during the first 3 waves were associated with SUD at wave 4 or with teen pregnancy. The association of, however, the association of concurrent ASB4, serious ASB, and early ASB with wave 4 MDD was strong and significantly, statistically significant. We found that a concurrent association of serious ASB with substance use disorder at wave 4, but no association between early ASB and wave 4 SUD. Perhaps the length of the follow-up was too long to predict SUD. So, serious ASB in childhood and early adolescence predicted MDD 11 years later during late adolescence and young adulthood. And this effect seemed to be explained only by concurrent ASB in the wave 4 follow-up. Depressive disorders in adulthood have been associated with increased or persistent childhood ASB in several studies. We were surprised, though, that neither SUD in adulthood nor teenage pregnancy were significantly related to ASB in childhood or early adolescence at either site, since other research that investigated the outcomes of excuse or persistent or increasing childhood ASB in adulthood has found ASB to be associated with drug abuse, risky social behavior, and depressive symptoms. We did not find that ASB4 predicted SUD at wave 4. This panel of results could indicate that either factors such as exposure to adversities and neighborhood effects may be more relevant to explain serious ASB risk in young adulthood in the study population. We did not expect such high rates of serious ASB in the young adults. 43% of the South Bronx sample reported serious ASB, more than double that observed in Puerto Rico. And this is important because serious ASB was defined as destroying property, physically cruel to other people, using a weapon, fire setting, breaking into a house, a building or a car, physically cruel to animals, whether once or twice a year, and stealing with confrontation. The levels of serious ASB are unusually high, particularly in the South Bronx, but high rates have been reported in other high-risk neighborhoods also. Why are rates of serious ASB as high in the South Bronx vs. Puerto Rico? Well, low SES could not be an explanation, since in both sites, a large percentage of the population live below the poverty level, even more in Puerto Rico than in the South Bronx. This is possibly related to minority status of Puerto Ricans in the South Bronx. In other samples of the same data, said higher rates of MDD and anxiety were found in the South Bronx as compared to Puerto Rico, were related to the consequences of minority status. And this was published by Maria Alegria. Puerto Ricans from the South Bronx reported much higher levels of discrimination, prejudice, poor neighborhoods and housing, greater mobility, more exposure to violence, and various other risk factors, which could be some of the important differences that explain these higher rates of serious ASB in the Bronx. For Puerto Rico, so what are the clinical implications of these findings? My take together with Hector's, if a Puerto Rican child or adolescent is male and presents serious ASB, whether in the South Bronx or Puerto Rico, his ASB is likely to persist into the next developmental period. The next implication is that the evidence of persistence is less strong in females, suggesting need for more longitudinal population-based studies in other contexts. And then if a child with serious ASB lives in a high-risk neighborhood, such as the South Bronx, where he or she is a member of a racial ethnic minority group, he or she is likely to have a higher level of ASB than a child living in a less toxic environment. Our findings advocate for the importance of early childhood community level interventions that might help derail these dangerous trajectories, particularly in neighborhoods where disadvantages concentrate. Thank you.